Roger. Thank you. And look forward to people's questions. I just wanted to, we listened to a presentation on, was it Thursday? Kind of Health Info Way, and expressed some concerns because I do believe there is some issue between Ontario's strategy and the CHI strategy, which appears to be a very centralized strategy as opposed towards a distributed concept like you've got here. So it'll be interesting to hear in the future what happens and how that goes. Anyway, I'd like to open that up to questions and comments from people in the audience. Oh,
Peter's not allowed.
He's not even allowed in here.
He's not allowed in here. I don't even know.
What did you say? Peter Barrick here from
Peter Barrick is with the OMA, the Ontario Medical Association, and Peter is one of the key partners of Smart System for Health, working with us on the EPP, the ePhysicians project. So if we have any questions relating to physicians, I will now, henceforth, defer to my friend Peter.
So normally we have screening at the door.
He's not a physician, but he pretends to know what he's talking about.
Thank you. Roger, I enjoyed your presentation. I'm Frank Costello from Magma Healthcare. When you had your chart out, and I think it was titled The Core Elements of the Strategy, I noticed that diagnostic imaging wasn't included in those groups, and we heard from many stakeholder groups that four main silos, if you will, that they want to see worked up in a centralized strategy would be the pharmacy type data, the labs, emergency record that you described, and of course diagnostic imaging. Are you factoring that in your strategy?
The difficulty, the answer to the question is essentially, in the short term, it's not part of the strategy. Diagnostic imaging, what was decided earlier on, not because it's not important, but because it was difficult. As you know, when it comes to diagnostic imaging, the bar is very, very low indeed. Like, not that the technology isn't there, and not that we couldn't do something, but that when you start talking about capturing digital images or images in digital form in hospitals or wherever they happen to be generated, that's something that very few hospitals have made the investments and so on. And it's beginning, though. It's starting to change. So in the short run, the answer is no, but and the focus has been instead is focusing on getting connectivity to diagnostic reports, as an example. So if you can't give me the image, at least give me the DI report, the radiology report. And that was felt to be a higher value immediately in the first setting, especially in a primary care type of setting. Now, increasingly, we're beginning to get bombarded by requests, mainly because of hospitals that are now across Ontario that are setting up collaboratives around PACS, picture archiving communication systems, and radiology, teleradiology. Because telemedicine, when you do telehealth, teleradiology, as you know, is not far behind. And we're now starting to see that in the north, there's a variety of initiatives that are popping up. I think it's just a matter of time before.
Girard communication system projects, and we're encouraged that they're funding that area, which could be a major catalyst and driver for some of the work that could very well fit your model.
Yep. The difficulty that we have is one of, like, it's very practical problems, bandwidth. Like, it's what's good about this type of initiative is you very quickly get to the real issue. It's no longer, I don't think the issue will be as much, in the Thunder Bay area. They're trying to put a PACS in the Thunder Bay area. They may even be working with you guys. They want to do it, and they think they have the money to do it, and they have the willingness to go about doing it. So if they can put it together, the last mile, if you will, the adding of the sufficient amount of bandwidth just to do that should be a minor problem for them because we're already there, if you know what I mean. So what we're hopeful, that's what the whole strategy is predicated upon, is that this is a network, for instance, that can be used and reused by anybody. So hopefully the cost of adding bandwidth isn't as high. But right now today, it's enough of an impediment.
What is the level of bandwidth right now?
Theoretically, it's obviously it's unlimited. It's what can be funded. So the formula that we use for allocating initial bandwidth to hospitals, particularly, was one based on bed size. It was arbitrary. We took a look at it and we said, if you put a meg megabyte circuit in a small hospital, that's good enough. If you take a very large complex hospital like a Sunnybrook or a UHN, 50, we typically go as high as 50. But you could go higher. There's no technical reason why you couldn't go higher. It's just money. But because it's all paid by the government, like the government is really worried about that, so we're trying to manage. We want to make sure that we don't end up with silliness out there, like people using networks capacity over long hauls, long distances, for reasons that are not good. You could implement, as you know, Dominic, you would know this, you could implement a poorly implemented client-server application which would just eat up any kind of bandwidth that you could possibly imagine. And it would make no sense to do that and put the server in Toronto and have it served out of Thunder Bay. But if the network is free, people will make decisions like that. So we have to be careful that we're not. But theoretically, there is no limit to and if it's good for healthcare, if it's a good place to spend, then I think eventually it will come.
Question from the Ontarians from local hospital.
Appreciate your presentation this afternoon. Just a question around, you talked about smart systems for health, providing solutions provider to provider from a healthcare perspective. What about from provider to patient? I'm wondering where that is in your strategy as we start to look at patient portals and different applications to link ourselves to our patients.
Excellent question. The question was about, in the presentation, very astute, you weren't sleeping, provider to provider. What about patients? What about patients to provider? What about, what's the question? The current eHealth strategy is about providers. It is helping the provider community get started and to get going. And I mentioned to you during the presentation that we're beginning to notice, and it's not a surprise for many of us, but it's important to walk that mile, that communities come into play. Like, it's not just good enough to have providers connected and working, but you have to get communities working together in order for value to start being generated. And that's difficult. That's not a technology problem. That now becomes an engineering problem, right? A social engineering type of issue. A number of times we've talked about the personal health record and connecting patients to providers. Why not providing email systems? Korea, interestingly, the Ministry of Health in Korea supplies free email to all the residents in Korea so they can communicate with each other and with their physicians. Now, some people have actually suggested that might be something that's important eventually for Ontario. At this point in time, we're not there. Now, you don't have to have a huge imagination to realize that this kind of infrastructure would support that sort of thing very, very easily. Right now, the focus is on the provider community. We've got to get the providers ready. There's a lot of suspicion, and that could be another presentation. There's a lot of suspicion. Physicians aren't all crazy about communicating directly with their patients. They're not paid for it, right? Like, there's a whole lot of disincentives to the use of messaging directly with patients. So I think it's coming, but we're not there yet.
What about hosting applications? You're setting up an infrastructure. What about if a group of providers or a provider wanting to establish that linkage?
Totally.
Some of your infrastructure?
Absolutely. The whole purpose of Smart Systems for Health was to hopefully provoke innovation. Like I've said this for ever since I've been there, that when you've done this and you're finished with it and people get it, like people in the healthcare system that are working there get it, like what they could do with this, and we see this, and when we're talking to hospitals and other groups, they begin to say, oh, you mean we were thinking of building our own data center and spending $3 million to build a secure data center, which, by the way, isn't a tenth as secure as the one you've already got. Can't we just on your floor? And the answer is yes. Now, just yes, but we have to go through the permission management game, okay? So don't come to me tomorrow and say, oh, hook me up with the truck backed up to the loading dock. Yeah, right. I'm not telling you that.
How long is the Ontario government prepared to wait to get primary care physicians involved at this level? maybe that should be directed to the OMA and what they're doing. Because,
Well, I'm not going to put Peter on the spot.
well, I will. Because if
Let me start
voice-
because I'm not sure, I think from what I've seen in other initiatives, there's only 2 provinces that I'm aware of, and there may be others, but there's only 2 that I'm aware of, that have formal programs that are addressing primary care reform and family physicians in general. And that's Alberta and Ontario. In Alberta, they put $15 million. The government put $15 million to help physicians computerize. And the physicians use that to buy computers, and the people really love the program. They want the government to repeat it. Ontario has put $150 million on the table. Now, Ontario is not 10 times. I think it's not 10 times bigger than Alberta. So I think on a per capita basis, more money has been put. So I think there's a recognition that clearly that indicates to me that the government is willing to fund this and to help it, and they've been told over and over and over again and they've engaged with the OMA, they've engaged with so it's a, but by the way, nobody's figured it out yet either. So I think that you have to be pretty bold to be able to invest money and to say, well, we don't really know what will work, but we'll tell you what we'll do. We'll promise them a certain amount of money, we'll work, and then we'll work with them collaboratively to see what does work. And right now they're in the process of designing that. So my sense is, Peter, I don't know if you want to jump in on this, but go ahead.
You should know, let me step back for a minute. The way you phrased the question was, how long is the Ontario government prepared to wait? I have no idea. You have to ask the government. Nevertheless, the government and the OMA are promoting the idea of electronic medical records and primary care reform very actively to the physician community. You should also know, step back one bit further, that 99.6% of all communications between the government, between the physician community, of which there are 21,000 providers, submit claims to the ministry electronically. There are 12.5 million claims that go in from the physician community each month, of which up to last month, over 800,000 are. So the physician community is already automated in the practices. They all have computers, and it's only those who are close to retirement, psychiatrists who are very low volume, those in part-time practice, and those who are moonlighting, who might submit cards. Everyone else uses computers. When I say everyone else, you have to then qualify and say it's the office staff primarily that use computers, not the physicians. It's a quantum leap to move the computer from the receptionist desk into the examining room. That requires a change in workflow, a whole different way of working within a practice that physicians at this point haven't been shown a business case to move in that direction. Because in the very early stages, we're developing the technology that enables physicians to work very quickly on the computer as they have been able to work with paper. Until we get to that, until we get champions and the pioneers actually out promoting the business case in a very demonstrable way to their colleagues, we're still trying to sell the concept. But it is working. I think e-physician is going to help a great deal, and we recognize that one of the biggest problems is the transition from a paper-based record to an electronic record requires a training process. It requires a change management process. And so we're putting in a very, very well-structured, highly complex change management process that will work for all physicians throughout the province, regardless of their level of competence with computers or whether they are completely unfamiliar with computers. We will be able to take them through the change management process to take advantage of the smart system.
Is there a system now where early adopters can be involved?
Many of them. There are quite a number of systems that exist at the moment which are electronic medical records.
Maybe the question that you're asking is a different one. Is it involvement in a specific system or involved in the decision-making?
No, it's not the decision.
It's the systems themselves.
Actually doing it.
With OHIP buildings and billings, they were generally told, do it electronically or you won't get paid. So they did it.
Well, you pay a penalty. They wouldn't get paid, but they paid a penalty.
You get paid, but the idea was there was incentive, or there was discipline for them not to do it. So, where's the incentive?
The ministry has on its books, and has had for some years, some of the physicians will know this, because I've talked about it, is that the ministry will move to electronic data transfer, EDT, as soon as it can. At the moment, around 35% of the profession submit claims via modem. The rest submit them via diskette. If the take-up of electronic data transmission is not sufficient, the ministry had, and maybe still has, the idea that they will impose the cost per diskette in the same way that they impose the cost per claim card, in order to move the profession from one technology to another. So yes, there are incentives. What the ministry calls incentives, the profession calls disincentives.
I'm surprised that it took this long for Peter to jump in. Usually when we're meeting together, we have to start this sooner, but you were good today. There are about 150 physicians or so across Ontario that are involved in various early pilots of one form or another, which are similar to what's been done in other provinces, and the ministry has had programs to fund them either totally or partially as innovators, the early champions, as you say. And it's difficult. Like every time you go into these, like every single one of them, I think there's only one exception, like are failures or successes, depending on your point of view. They're not scalable. You can't roll out these solutions to 12,000. So people are working together to try to figure this out. But this is the toughest nut to crack in the whole strategy, is getting physicians, finding a way to incent the physicians and provide the incentives. And it's money. It's going to take money, but it's at the end of the day, what will work is when it actually delivers value to it.
A question here and then in the back.
Quick question. I was just a bit curious about how far SSHA's role goes in terms of, as infrastructure providers, how far do you go in terms of being able to provide, like if someone wants to host an application, how letting them know their scalability requirements and availability and all those issues, like are you involved in that, or would the agency be involved?
The question is, how far do we go? And I think the example was hosting, but it could be with networks as well, probably in terms of sizing and bandwidth analysis and so on and so forth. The toughest one is hosting, because most of the other services they're kind of like commodities. Like network is a commodity today, sort of, except unless you're in Pickle Lake, Ontario, in which case you got to get innovative, because you're not going to get high bandwidth in certain parts of the province, and we know that already. So we're working with certain communities to try to figure those out. But most of the services are commodities. Email, PKI, although it's something new, it's technologically it's pretty straightforward. The toughest one is hosting, and I don't think that there isn't anything that we've done so far that's the same. It's always a little bit different. Sometimes SSH is playing a greater role technically in supporting or operating the servers and so on. Most of the time, we do not take an ownership role. We're not the custodians of the data. It's very important that the client continues to own the data and to manage it and have custody and so on and so forth. So it really depends on the answer to your question. It very much depends on the organization. Typically, though, organizations that want to do this are already equipped for that. They're just missing a final solution. Like if you've got 15 hospitals that want to collaborate on a single Meditech site, and there's a number of hospitals in this province that would love to do that, and we're in fact talking to some of them. They already know how to do this, and they're probably just missing the final ingredient, which is a secure floor space or something like that. If we got into a situation where we were, in my opinion, and this is just my opinion, if we got into a situation with a customer where they lacked the knowledge or the sophistication to manage this in this kind of an environment, it's probably not a good thing for us to get involved with, because it's very important that they maintain custody. These records do belong to them, and they have to be able to discharge that accountability.
Doug?
My question is about the community and community care access centers. It sounds like your project pushes connectivity out to the CCAC, but not much further beyond that. I'm wondering if there's funds available for that sort of work. CCACs are taking, I'm not directly involved with them, but I have had some contact. Thousands of referrals a year.
Correct.
By hacks from
Correct.
various agencies in the community out to
Yep.
other various
Yep.
agencies in the community that are not.
Yeah. The CCACs have created a project group called C3. So there are 43 CCACs in the province of Ontario, connected to, I think it's 150 organizations that are provider organizations that are connected with them. So if you think about this, it's 43, maybe several hundred service group. What they've done, the 43 CCAC head offices in Ontario have come together under a continuing care council. So from a governance point of view, all 43 CCACs have agreed to play together to coordinate their activities from an IT point of view together. They've created an IT group. It's called the C3 group, the Community Care Connects group. It's a fancy title. So just to explain that they're working together, it's not without their problems. Like, 43 CCACs from Ottawa all the way to Kenora is not necessarily going to, people aren't going to be, it's not going to be harmonious all the time, but there's a commitment to making it work. They have made a commitment to connect, so they're all connected today. Not all the providers are connected, but we're working with some to connect all the other providers. So it's an evolution, but they will all be connected. They all have a common email system. So for the first time, the CCACs in Ontario in the last 2 years have been able to email with each other, which doesn't sound like a lot, but they're able to do some pretty innovative things with that. From care workers that are in the home and in the community are able to communicate back and forth, don't have to phone, and so on. So email is an important component. There are also 2 important RFPs that are currently, right now today, are still outstanding. 2 requests for proposals were let by C3, by the CCACs, by the Ministry of Health on behalf of the CCACs. One was for a common financial system. So the CCACs have made a commitment that they're going to implement the same financial system across all 43 CCACs, financial administration, general ledger, all that kind of boring stuff. And more importantly, a common assessment tool. So they are committed to implementing a common assessment, client assessment tool, so that all long-term care patients and all home care patients would be assessed using a common assessment instrument that would then be available. Now, this is a pretty, for those of you who know the community space, this is an important project from the point of view of care, from a care or from a client care point of view. It'll be very important. We've already gotten messages from CCACs and hospitals that want to communicate this information between themselves. And when we start to get there, between referrals, between hospitals and CCACs and so on, that's where some of the value will start to be generated. I hope that was, yeah.
We're just about, in fact, we're over time, so just one final question, quick answer.
Just following up on that,